You're going to hear from some presenters this afternoon who cover some pretty advanced terrain, and I am going to instead do some level setting to make sure that we're organized around some basic concepts that we all share as we go into this advanced terrain. The work, first of all, what is the State Innovation Model Initiative, the SIM? It's an initiative that has been undertaken under the bold leadership of the Lieutenant Governor now for a couple of years. I've had the privilege of working for the Lieutenant Governor, but also for a pretty diverse governance structure. We have had an enormous amount of input and investment from the employer community, health plans, consumers and consumer advocates who number more than 50 in our overarching advisory structure, work group, consumer advisory board and such, providers and state agency reps. And they've come together through countless meetings and planning sessions to advise the state on how we put together a series of initiatives, 7 to 10 distinct initiatives that together should help us advance our performance in some of these trouble areas that you've just seen. One of the things the steering committee identified very early on is that health equity needs to be, if you look at the data that Dr. Dalal presents, you can't have a health care improvement or health improvement strategy without directly confronting the problem of health inequities. And if you're going to confront the problem of health inequities, it means you have to have a strategy for that. It's not going to happen simply because you have a method of improving quality on A1C control or asthma control or whatnot. In thinking about health equity, it helps to have a particular community with needs in mind. And I've had the good fortune of learning from what the Consumer Advisory Board and the Khmer advocates did last fall when they convened the Southeast Asian Forum listening session. And what was striking about that is that, well, first of all, how many of you recall the magnitude of the health inequities that Dr. Dalal present related to the Asian population? Big problem, not a big problem? Doesn't look like it's a big problem. So one of the things that's really striking is that actually it is, if you look closely enough, it is a big problem. You have 45% of Cambodians with post-traumatic stress disorder. You have higher rates amongst all the Southeast Asian communities in things like in depression. You have a higher risk in this population of diabetes, hypertension, cardiovascular disease, cervical cancer, and more. Enormous barriers to care around low cultural acceptance of preventive health or getting engaged in healthcare around chronic illness, self-management, and other social factors are also a hindrance. And then going back to this question about quality improvement and how you actually focus on a particular population improving, how many folks work for organizations now that have a quality improvement strategy around healthcare? Pretty much everybody. How many of you have one that's specifically about health equity, closing health equity gaps? How many of you have one that's focused on Southeast Asian subpopulation? Probably nobody today, and I would challenge you to, I would suggest that most of you probably have no idea how many Southeast Asians with these risk factors you're serving, how well you're serving them, and exactly where, and what methods you might actually be able to use to improve service for them. So as a distinct subpopulation, they're not captured in today's, very few OMB race ethnicity categories. And as a consequence, the needs of this population, like so many other subpopulations, basically go unrecognized. So that having that community in mind has been key. Another is recognizing that when you think about health determinants of mortality, our ability to influence improvement through healthcare is a relatively small 10% part of the equation. Much of the opportunity for improvement in health inequities lies in the social, environmental, and behavioral health determinants. And what that means is that if you're going after health disparities, you definitely need to, on healthcare quality, engage healthcare organizations as leaders. But if you want to solve for that other 60%, you have to add in the broader community and figure out a way to drive improvement at the level of the community. So we're trying to invent together, collectively, a future that's not about the fee-for-service system that we've had around for so many years, that's notable for a lack of accountability for particular patient populations, and notably for paying for how much providers do and not actually for the kind of results they get. We're focused on a 2.0 solution, an accountable care solution, where organizations are taking accountability for patient populations. They're competing on things like healthcare outcomes and consumer experience. They're facing challenges about how to communicate across a diverse medical neighborhood, but also how to engage with community partners. There's another stage, which there are fewer established models for the 3.0 system, which we call health enhancement communities. And in that 3.0 system, you have methods for promoting advancement and accountability for all community members. You look at means to promote cooperation amongst all the participants in the community, including folks who compete in another space. And you look at social demographic factors that actually affect the prevalence of disorder, how likely it is you get diabetes as opposed to how well you manage it. I'm going to focus initially on the 2.0 system. So we're actually pretty well on the way to the 2.0 system. The as-is title for the fee-for-service is not entirely accurate. Medicare and Medicaid and commercial payers have been pressing our primary care foundation to advance. And because of those expectations, primary care providers have banded together to form advanced networks, what we call advanced networks, what Medicare calls ACOs. But basically, groups of primary care physicians may include specialists, hospital partners, home health, who share resources and infrastructure to improve their ability to drive improvement in quality. The advanced networks, rather than, unlike individual practice, are responsible for, accountable for sometimes tens of thousands, if not more than 100,000 patients. Our goal with SIM is to drive improvement by focusing on ways to improve care delivery in these organizations that are already directionally moving there, but strategically with some investments in care delivery reform, and to couple that with a deeper investment in value-based payment models that actually will reward some of those care delivery reforms. I think, as Dr. Dalal said, the system you designed is the systems we have today are perfectly designed to get the outcomes we get, which includes health inequities. We need to dial into a solution for value-based payments so that the exciting programs you hear about this morning are not driven by a local champion and an interest in doing the right thing, but they're actually happening because it works from a business sense and because it's the right thing. These things the system has to make it natural to adopt some of these innovative practices if we want to see them adopted on a widespread basis and not be the exceptional things that we point to and applaud in annual meetings. So we have maybe 15 to 20, we have 20 advanced networks out there today distributed across Connecticut. This isn't actually where they are or exactly how many. What we're doing is partnering with the Department of Social Services with the Medicaid Quality Improvement Shared Savings Program. DSS is going to select a subset of those advanced networks in the first wave. They're going to do this procurement in June, and then there's going to be a second wave next year. So we're going to focus our effort on supporting the advancement of those systems through two programs, the Advanced Medical Home Program, which is focused on facilitating improvement within the four walls of the practice, and then we have an organization-wide program called the Community and Clinical Integration Program, which is very much at the heart of what today's meeting is about. The Community and Clinical Integration Program is designed to create capabilities that would be adopted throughout the network, all the primary care practices, focus on things like comprehensive care management for patients with complex health needs, including social risks, health equity improvement, where we're looking at methods to both drive continuous improvement in the reduction of health inequities and also piloting some new ways of addressing health equity improvement and behavioral health integration. So in these programs collectively, the kinds of things we focus on are person-centered assessments, that consider, require a more expansive look at the whole person, things like social behavior and economic risks, capturing race, ethnicity, and language at a substantially more granular level than the OMB categories, and ensuring that you think about and design treatment solutions that are organized around values, preferences, goals, cultural beliefs, and so forth. That you have a medical home team that extends to create a comprehensive care team that includes folks outside of the practice who can be key partners. That you enlist community health workers who can be an essential bridge to connecting with communities that are otherwise hard to serve. They can help with patient navigation, they can help with community linkages, and they can also help simply do chronic illness self-management education in a way that some populations will be much more responsive to. Doing subpopulation analytics to drive improvement that's focused on the subpopulations that you're struggling with the most. Having interventions that are targeted toward those interventions, and then baking in that kind of practice and continuous quality improvement. Another focus is facilitating coordination and communication with key partners outside of the advanced network, and also, especially if you're taking on social determinant risks, cultural health organizations, housing services, social services that are going to be necessary if you're going to try to address some of the barriers to, that get in the way of the health care outcomes we're trying to influence. In addition, because in most regions or service areas, you've got a number of advanced networks all trying to coordinate with the same community organizations, which are shared resources, we're going to be focusing on the development of community health collaboratives. And those community health collaboratives will involve multi-stakeholder, cross-sector partners from the community to develop consensus protocols, to basically develop relationships amongst the various actors who are trying to solve for the same problems, and to monitor and improve the overall performance in the community. So that's the Community and Clinical Integration Program, I think our centerpiece care delivery reform initiative in SIM. We're going to couple that with some work in payment reform. As Bill will talk about a little bit, immediately after me, there's the Medicaid Quality Improvement and Shared Savings Program, and we're also doing work on the quality scorecard that's the basis for shared savings. So with regard to value-based payment, many of the advanced networks in Connecticut, about 15 of them, already have relationships with Medicare and commercial shared savings programs. And our goal is to introduce a Medicaid shared savings program which will bring substantially greater portion of the patients that they're accountable for into a payment relationship that rewards them for being more flexible, innovative, and being able to drive improvement and also affordability over time. Our goal would be to get to something on the order of 70% or more of these new payment models. You cannot reinvent the culture of a particular health organization if 20% of your patients, the reimbursement is in some advanced payment, and everything else is still just basically pay for how much you do. So this is really key. And Medicaid, of course, is 20% of the state's population. The other way we're trying to drive improvement is by getting consensus among the payers on quality scorecards, and especially ensuring that care experience is part of every value-based payment scorecard for shared savings, and that we actually put on the scorecard something that isn't on any scorecard today that I've seen in the nation, which is to actually measure and reward improvements in health equity on things like colorectal cancer screening, A1C control, and hypertension control. So putting it all together, we think we can drive improvement for these organizations. For the community we started with, we focus on depression and trauma screening in addition to substance use and anxiety. We have a focus on chronic illness self-management around diabetes, hypertension, and asthma. We specifically try to address barriers to care not only in the nature of the self-management activities that are done, but employing community health workers to bridge the cultural gap, and requiring a more granular data collection that maps better to the kind of communities and populations that are served by the provider. So we've been at this I often get the question, well, we just did, we implemented all these EHRs and, we've got these new payment models out there, Medicare Shared Savings Program, like, I'm ready to be done. We should be there yet. And actually, I think we're going to be in the car for a while. We've been 60 years in developing and honing a perfect system for giving us the results that we get today. And it's going to take us some time to invent and reinvent the newest models to get them to dial into the kind of outcomes we're focused on. So a few comments on the health enhancement community concept. So if things go well, advanced networks will emerge and they're going to be better connected with their community partners. And the challenge is how to create a regional or community focus and to create cooperative relationships and linkages amongst all the members of the community to include other cross-sector stakeholders like community development organizations, city planners, and so forth, health departments, and potentially to have some means to have shared governance in the community, so that there's accountability for improvement for all residents of the community on performance areas like this. To give you an example, the usual scorecard has organizations accountable for the patients who are attributed to them. Those are the top, down to chronic and acute care. Adding community health improvement metrics that reflect the health of the community, not simply the patients who happen to be attributed to the advanced networks. Because in fact, in Medicaid, 30% or more of the patients of the individuals Medicaid are never attributed to an advanced network. So you've got a whole bunch of people who aren't even on the scorecard. So the concept here is to have a scorecard that rewards an advanced network for not only their attributed consumers, but also some collective health targets that relate to overall all community members, such as obesity prevalence and diabetes prevalence. The 3.0 system presents a whole lot of challenges for us. How do you measure quality at the community level? How do we incentivize stakeholders, not only advanced networks, for example, through a scorecard that's enhanced in the way I just described, but some of the other stakeholders who are key, housing code enforcement and so forth? Do we need additional infrastructure, or can we leverage the existing infrastructure that's being built through the health system community? How do we fund the community investments that aren't the kind of thing necessarily that a health system is going to make investments in, but would certainly support? And how do we engage consumers in that process? So the visual for this one, of course, is that unlike the 2.0 system, we have working models that we're refining and that have been rolled out for several years. Across the nation, SIM states are trying to develop accountable community concepts, but there are really no working models. So this is the new frontier, and I think as you'll see from segment 3, there's some good work happening that should inform that conversation, but there is a whole lot of work to be done into standing up what could be an accountable community model that really drives the kind of interest and innovation that you see around accountable care organizations at the level of the community.